April 27th. The first one we're going to look at is the changes to E04A, acute coronary syndrome, and STEMI. So this one, we haven't really reinvented the wheel too much. There's just been an extra pathway added right now. So as for work scope, pretty standard. We got rid of all the color boxes. Those have been gone for a bit now for most of these care maps. So there's a statement of who can do what at what levels will be indicated by actual letters. So indications to use this care map. So if there's any chest discomfort, pain, pressure, heaviness, or other symptoms, making you think that your patient's having a heart attack, we're going to use this care map here. So to use the actual bypass itself, though, we need to have a patient that has known or suspected ST elevation, myocardial infarction, or STEMI on our ECG. And also the big one is the patient can arrive at St. Boniface Hospital cath lab within 100 minutes from first contact of EMS. So that's important with the timelines. So when we think of stroke, our clock starts ticking for stroke bypass once the patient starts having symptoms. For STEMI bypass, the clock starts ticking once we arrive on scene. So the other thing as well is obviously we're not going to bypass to St. Boniface if we have a reason to go to a closer emergency department. So contraindications, so a patient has a decreased LOC, so it's kind of hard to do a proper assessment if your patient's semi-conscious. If you have any suspected respiratory failure, signs of shock, sepsis, excuse me. So when it says shock, they're obviously going to be in some kind of shock because they're having a heart attack, but more so like you're not compensating shock. And obviously respiratory failure, that's a bit of a deal. So if there's any known or suspected current internal bleeding, excluding menstruation, obviously if that's normal bleeding, if there's any kind of intra-abdominal bleeds, things like that. If you have a known or suspected aortic dissection. So aortic dissections usually present with an excruciating anterior chest or intrascapular pain, often described as tearing or ripping, that usually has a sudden onset. So this pain typically migrates from an original location to some elsewhere throughout the chest as the dissection extends along the aorta. So with this pain as well, this may be accompanied by syncope because it hurts. So patients tend to get syncopal episodes. It could also be hypotension, tachycardia. And that's due to active bleeding. So signs and symptoms of shock. And there could also be a difference of about 30 millimeters of mercury difference between each limb when you're doing your blood pressure. Another big one as well is JVD might be present due to cardiac tamponade, or you may get pleural effusion upon auscultation of the chest due to leakage of blood or inflammatory fluid into the pleural space. So when you do your whole assessment there, if that's kind of what they're presenting with, we're probably going to want to go to a closer facility. If they're having a known or suspected acute stroke, and as a side note, if they are having an aortic aneurysm, that can also cause chest pain with stroke symptoms. So that's something to be suspicious of as well. If they've had any recent significant head trauma, and if they have an advanced healthcare directive indicating comfort care. So obviously, if they're palliative and they don't want to be transported to the hospital, we're going to have to take that into consideration. So acute coronary syndrome, with the new addition is the EMR path added to the new care map. So with this one here, this has been added specifically for EMRs. So when it comes to a patient that's presenting with cardiac chest pain, you're going to administer ASA. But the new change here is for giving nitro. EMRs must contact online medical support for sublingual nitroglycerin administration. So if they have their own as an EMR, you're allowed to assist the patient take their own sublingual nitroglycerin. But if you're going to be the one giving it out of your bag, you need to contact online medical support first. And as always, consider if you need ALS and then transport. So for PCPs and up, ideally we want to acquire an EKG within 10 minutes of arrival. And again, that's going into the timelines of can we get to the cath lab within 100 minutes. So obviously we need to do a 12 lead, we need to check things out. So we probably want to start off, try to get our 12 lead as soon as we can. We can look at giving ASA as per M37.1 medication profile. We can look at giving sublingual nitroglycerin and apply a nitro patch as per M21 nitroglycerin, which we're going to talk about a little bit more in a few minutes. The big thing, obviously, with nitro is patients with right ventricular infarct may be dependent on right ventricular filling to maintain adequate cardiac output. So the concern with giving nitro is that if they are having that right-sided MI, that's going to cause a drop in blood pressure and decrease cardiac output. So that's another reason to really do your 12 lead first, because if you're having a right-sided MI, we might want to stay away from the nitrates. If they do become hypotensive, we obviously want to stop giving nitrates. If they have a patch on, take it off. And you can give fluid boluses. But the big thing is to make sure that you're not fluid overloading your patient. So if you drop their blood pressure because you gave them nitro and you're like, "Oh, I'll just fix it with fluid," but now their chest is all congested with fluid because their heart's not pumping properly, you're creating pulmonary edema, that can cause problems. So just be cautious and keep that in mind when you're giving nitro. So the other thing to keep in mind with nitro is that it's given for pain relief and comfort for the patient. So if you have a patient that's having those symptoms like just jaw pain, feeling kind of dizzy, not like actual cardiac chest pain, you may just not give nitro, because if they're relatively comfortable already, they're just not feeling well, they're just fatigued, and that's the only symptom they have of their STEMI. Nitro may not relieve that. So kind of look at the pros and cons of giving your patient nitro. We just don't automatically give it to everybody just because. So if you're an ICP, we consider opiate pain relief. So basically, if after like 2 or 3 sprays of nitro, nothing's really working for you, it's not helping relieve pain, we can look at fentanyl or morphine. So with recent updates, especially with going along with heart and stroke guidelines, fentanyl is the preferred choice for pain control for MI patients. As they did a lot of studies, they actually restudied the studies, and they found that morphine is actually causes more heart damage when given to a patient with ACS. So the recommendation was to give fentanyl. So that's as per the heart and stroke. But for ours, it just says opiate if ongoing pain. So if you find that morphine's working for you, great. Obviously, if you're having a lot of pain, we need to take that pressure off the patient. And if that's what's working, awesome. But we have to keep in mind that that morphine can cause more heart damage. Another thing with opiates as well, that again, that right-sided MI, they just puts them at higher risk for hypotension. So that's why we want to do a 12 lead first. And the big thing with the care map here is it never mentions giving oxygen. So the other thing as well is that giving morphine can cause more heart damage. So can giving too much oxygen. So the days of 15 liters non-rebreathe, crank it up, everybody gets O2, those days are done. With what studies found is that with excessive oxygenation for cardiac patients, it actually increased heart damage as well. So if your patient has a SAT greater than 90 and they're not showing signs of respiratory distress, cyanosis, things like that, we're good. We don't need to give them extra oxygen. Sometimes as a comfort measure, though, it's not wrong. Just put a nasal cannula on 1 or 2 liters just to give the patient some comfort, give them a little bit extra air. But again, we don't need to be cranking O2. We don't need SATs of 100%. That actually causes more damage to their heart. So a SATs between 90 to 94%, that's good, as long as they're not showing symptoms of cyanosis or respiratory distress. So now we're going to look, does the ECG indicate a possible STEMI? So we did our 12 lead, we gave our patient pain control, all that good stuff. Let's actually look at the rhythm. So under the care map here, paramedics will consider an ST elevation myocardial infarction if the monitor defibrillator says STEMI. So obviously if it prompts STEMI, they're probably having a STEMI. The other things that might prompt on the ZOL here. So this list here comes from the actual ZOL 12 lead interpretive algorithm physician's guide. So other things that might stand out that don't specifically say STEMI, but definitely put across that there's probably some kind of MI or some kind of cardiac event happening. So it could say probable acute ST elevation, where in the heart it is, infarct, same thing, probable acute ST elevation, wherever it is, infarct, acute anterior infarct, probably acute, or infarct, probably acute with location, where it is, inferior, anterior, anterior lateral, posterior inferior, acute myocardial infarction. So all this stuff here, you kind of want to look and go, okay, that's concerning. My patient's having a lot of chest pain, dizziness, fatigue. Now it's saying that there's a posterior, inferior, anterior myocardial infarction. I would say that's concerning. So you might want to make a phone call on that one. So if the ECG shows any of the following, so if you're going to actually interpret your 12 lead, it's going to look for ST segment elevation at the J point of at least 1 millimeter in any 2 or more contiguous leads. So when we look at contiguous leads, so we're looking at the anatomical locations of the heart here. So for example, when it breaks it down in the color box here, these are your contiguous leads. So if you've got V1, V2 ST elevation, yeah, it's probably a STEMI. But if you have a bit of ST elevation V1 and then you notice there's some in lead 3, not quite what we're looking for. There's definitely a cardiac event going on, but it's not those continuous leads. So it's just something to look at. Where are we actually seeing this ST elevation? If there's ST elevation in just one lead, so let's say you're seeing ST elevation in lead V3 and that's it, not necessarily diagnosable as a STEMI. If you're concerned, call the cardiologist, but we're looking for more than one lead for this care map here. The other thing we're looking for is ST elevation at the J point leads V2 or V3 of at least 2 millimeters in males over 40, at least 2.5 millimeters in males under 40, and at least 1.5 millimeters in all adult females. So with this here, the J point, if we're just talking about J points, there's a little bit of a picture there. It's the junction between the termination of the QRS complex and the beginning of the ST segment. So as you can see in the picture there, it shows different J point, depression, elevation. That's what we're looking at. And when it comes to J point elevation, if you're not going to interpret the 12 lead yourself, it's very important on the ZOL that if you go to the demographic screen like it shows here on your ZOL, you need to put the age and sex of your patient into there, because the ZOL will look for that J point elevation as well. So if you're just doing a 12 lead on everybody, the go-to for the ZOL is 40-year-old male. So if you have a 56-year-old female, it's going to look for different ST elevation for males versus females. So you might actually miss your STEMIs because it's not reading that correct J point elevation. So I might say, no, STEMI, you're good based on the J point, whereas as said previously in females, it may be a little bit lower. So we want to make sure we're putting our patient demographics into the ZOL before we do our 12 lead. So it could also say that they have a new or presumed left bundle branch block. So with this here, this is one of the criteria. There's different, read a few textbooks. There's different ways to tell. There's like Sarabosa's criteria, which I'm not going to go into in this class. But with left bundle branch criteria, you may see that B1 presents with a dominant S wave, and B6 presents with broad notched M-shaped R wave. So like it shows in the picture here. So you're going to have YQRSs, that dominant S wave in B1. Broad monophasic R wave and lateral leads as well. And you're going to have a prolonged R wave peak time in V5 through V6, because again, it's got that notch there due to the electrical conduction through the heart. It's not going to go throughout the heart normally. It's going to have that delay, so that's what causes that notching. Also, or you could just look at the ZOL and it'll say suspected left bundle branch block. Done. So left bundle branch blocks affect the way ST elevation is noted on the monitor. So it was actually requested by St. Boniface Hospital that if we have a patient with a left bundle branch block, we call it in, because we can't determine what the ST elevation is looking like because there's that disruption in where the electricity is going in the heart. The big thing as well is to ask the patient, is this new? Have they been diagnosed with a left bundle branch block, or is it old? So because obviously if they've had it for a while, that's going to affect things as well versus this is a new onset. So if you do a 12 lead and there's no sign of STEMI on the initial 12 lead, if time and patient condition permits, a 15 lead should be performed, and along with follow-up 12 leads. So if you're not familiar with doing 15 leads, so just here I've put a picture. So what we're going to do a right-sided or a 15 lead is you're going to move your V4 from the left side of the chest and move it to the right side of the chest. So your V4 is going to move to mid-clavicular line, fifth intercostal space on the right. So then V4 now becomes V4R. It's very important that you do your skin prep before you put the leads on, and use a new electrode each time. Don't unstick one from the left and just restick it. Make sure you're using a new lead each time, or new electrode each time. So to do on the back there, we're going to take V5, and we're going to move it to the back on the fifth intercostal space mid-scapulary line, and then this lead becomes V8. And then we're going to take V6 and we're going to place it on the fifth intercostal space left of the spine, midway between V8. So this becomes V9. So we're going to take that V6, we got V8, the spine, put V6 in the middle, that becomes V9. The big thing as well is when you do your printout, make sure to label your 12 lead, because the ZOL doesn't know you're doing a 15 lead. So you just move the leads, push 12 lead, just like you would normally, and then it'll just print it out as a 12 lead. So make sure on your actual 12 lead, you change your V4 to V4R, V5 to V8, V6 to V9. I like to write 15 lead across the top because if I'm going to send it to the STEMI physician, then they can tell which one's the 12 lead, which one's the 15 lead as well. So again, if they're presenting like total cardiac patient, but the 12 lead's like, it's okay. Could be they just haven't started developing ST elevation yet, or it could be that we're not checking the whole heart. So we should check the right side as well. So if it does say STEMI, we're going to call the code STEMI physician, but only if you can reasonably judge that the 100-minute window to the cath lab can be met by direct ground transport. We always check with the physician first before departure and before we confirm air transport. And we'll talk a little bit more about that in a minute. So the answer is no. So let's say you're 2.5 hours away from St. Boniface. So these patients may still benefit from going to an ED capable of providing emergent fibrillary therapy, followed by a prompt transport to the cath labs. Go to a close facility, stabilize them, get treatment going, then go to St. Boniface. So with this, what we're going to do is we're going to start going to the closest ED and call online medical support. So with online medical support, we have ticagrelor and enoxaparin. Online medical can tell us to get that medication as well, not just the STEMI physician. So that way we can start that therapy en route to the hospital. And if we have time, we're going to perform the TNK checklist while we're en route. So with that, it's been requested that if we know we got a very sick STEMI patient, we've started doing therapy, they're probably going to get transferred right away. It's been kind of requested if we can try to stay with the patient, because we know if we're going to go in, stabilize, and head on down the road in 10 minutes, you might as well just stick around and wait for that transfer. Again, based on availability and what's going on with the patient. So this is a TNK checklist. I'm not going to read through the whole thing here, but basically just want to read through it. A lot of it's just your sample history as well, just like go through medical conditions, vital signs, things like that. And definitely patient history is a big one. We're just seeing what the risk of bleeding is for these patients. So if you can get to St. Boniface within 100 minutes, paramedics will contact dispatch and request the name and the phone number for the code STEMI physician, and that number will be given to you. If you're not able to call and then get through to the STEMI physician, you can call the St. Boniface paging operator and request to speak to the on-call interventional cardiologist for a code 25 outside call. So the yellow box they put there, that's right in the care map. So the numbers are there. So you should be able to access it through the care map, get the numbers that you need. If you're not able to get through to anybody, just no one's picking up the phone that day, we can contact online medical and talk to them and request whether we bypass. And that might just mean that we don't necessarily go to the cath lab. It just means we can bypass a closer hospital, go straight to St. Boniface ER based on our patient presentation. And again, online medical can give us that direction, give enoxaparin or ticagrelor, whereas otherwise we may not. So it's definitely beneficial for your patient. When contacting the STEMI physician, ensure to communicate the patient's name, age, gender, current symptoms, when it started, their relevant medical history, medications they've taken, if they have meds, but they haven't been taking them, any allergies, what their vital signs, what your assessment is. So a lot of this just like a triage report, basically. So does the STEMI physician authorize transport to the cath lab? If it's no, we're going to close this ED and contact online medical, like I was saying, so they can direct us over the phone that way. If the doctor says yes, so we go straight to the cath lab, or they may just say go to the ER. So either way, we've got direction for bypass. If the patient's stable on arrival at St. Boniface, based on what the cardiologists tell you, you could just go directly to the cath lab. But if they become unstable en route and we're close to St. Boniface, we're just going to carry on, but we might redirect to go to the ER as opposed to the cath lab. If the patient deteriorates while en route, obviously go to your closest ED. If they go into respiratory rest and they're like bratting down and you're like, I can't deal with this by myself, definitely go to the closest facility, even though you've been given bypass. So when we contact the STEMI physician, then we can then give a ticagrelor, enoxaparin as direction by the physician and in correlation with medication profiles M37.2 and M43. So the big thing is as well is that physicians in the hospital may not be familiar with our med profile. So when they tell you to give a certain dose of medication, they may tell you to give a lot more than what the med profile says is their max dose. So we are not to exceed the max dose, because if our patient gets too much of a medication, they start bleeding out. In the hospital, they can deal with that relatively quickly, I guess. I wouldn't say easily, but they can deal with it a lot quicker than we can. But if we have a patient in the back of the ambulance and they start bleeding out, there's really not much we can do about it. So we're going to not overdose our patient on anticoagulants. So the other thing as well is here, so now it says consider helicopter. So St. Boniface was saying they were getting a lot of phone calls from people 2-3 hours away saying, well, if I get a helicopter, I can get your patient there within 100 minutes. They only want us calling if it's 100 minutes by ground transport, and then we can look at getting a helicopter. That's a little different going to HSC than St. B, because HSC has a helipad. So the helicopter can land right on the hospital. St. Boniface, the helicopter has to land at the airport, meet up with the ground crew. Then that ground crew has to drive them to St. Boniface. So it's still going to be a bit of a time. So if you're looking at you can get to St. B within 100 minutes driving, but it's greater than 60 minutes, then we can start requesting the helicopter. Because honestly, if the cardiac physician says, yep, your patient's having a STEMI, we're all full up here, we can't take anybody right now, there's no point in getting a helicopter coming, because they're not going to take your patient anyways. So we need to make sure we're contacting the STEMI physician first and then looking at other transport decisions for our patients. Any questions? All right, moving on. So the next thing we're going to go over, since we're just doing STEMI, is we are going to do cover the new M21 nitroglycerin update here. So updated medication profile is really that EMR is only allowed to give sublingual nitroglycerin after consultation with online medical supports, kind of like what I mentioned, the STEMI bypass care map there. So indications for nitro. So obviously if they're having chest pain or discomfort consistent with or suspicious for MI. So like I said, if they're not having chest pain, they're having a cardiac event, but like the pain's just not there. They're just got numbness or tingling. We're not necessarily going to give nitro, even though the care map suggests it. It's not needed as symptom relief. So the other thing to keep in mind when it comes to nitro, if your patient's chest pain is due to a rate issue, so if they're extremely tachycardic, so they've got a resting heart rate of 200, or they're extremely bradycardic and they have a heart rate of 20, that chest pain they're having is not, you're not going to give nitroglycerin for that because that's more of hypoxic, the heart's working really hard or going really slow, perfusion sucks. Nitro's not going to fix that chest pain. So if it's a rate-related chest pain, that's not an indication for nitro. So just something to keep in mind there. The other indication, though, for giving nitro is pulmonary edema and congestive heart failure. So contraindications, obviously, if they're hypersensitive, they can't have it. So that could mean that they get allergic reaction or just that their blood pressure drops all the time, no matter whether left-sided, right-sided MI, whatever. If they have it, they just have a drop in blood pressure. We might want to stay away from it. If they're using it following within the last 24 hours, so any ED medications, so Viagra, Cialis, Levitra, so it's just 24 hours, we're not going to give it because, again, that's a vasodilator as well, so we don't want to over vasodilate them. If the patient's presenting as hypotension, so systolic blood pressure less than 90 or greater than 30 millimeters of mercury or greater below baseline. So if you have a low blood pressure, or based on what their normal blood pressure is. So they might have a blood pressure 120 over 80, but their normal blood pressure is sitting around 160. That could be hypotensive for them. So look at your perfusion, things like that as well. Radial pulse present, signs of shock. Or if we give the medication and there's, like I said, that 30 millimeters mercury drop, we're not going to give another spray. We don't want to give nitro for patients with suspected increased intracranial pressure because nitro has been shown in studies to actually cause an increase in intracranial pressure and decrease in intracranial perfusion, which isn't really good for the brain. So we're not going to be giving nitro to these patients. An established diagnosis of any of the following. So these are things we're probably not going to figure out on scene, but if we get a medical history, it'd be good to know. So there may be aortic or mitral stenosis, which is a narrowing of the heart's aortic or mitral valves, which causes restriction of blood flow. They could have pericardial tamponade, which is fluid buildup around the heart. They could have constrictive pericarditis, which is a thickening and scarring of the actual pericardium itself. Could have restrictive cardiomyopathies. So this is the stiffening of the heart resulting in reduced cardiac filling, so it's not able to fill up as well. And hypertrophic cardiomyopathy. So that's actually thickening of the heart muscle causing decreased cardiac output. So there's just too much muscle, not enough space for the fluid. So again, but one thing it doesn't say in here for contraindications, because it's more of a relative contraindications, just use at your own cautions if you suspect right-sided MI. So that'd be a relative contraindication as opposed to steadfast one. So to give the dosing, it's 0.4 milligrams spray under the tongue. Not really anything new there. So for transdermal dosing, we have the patch as well. So if your patient's 17 years and older, it's 0.4 milligram an hour patch. The ideal placement of putting these patches is just on the left side of the chest. The reasons for putting it on the left side of the chest is that if your patient starts becoming hypotensive, they go into cardiac arrest, it's easy to find, pull it off. It's not going to be the way your defib pads, anything like that. So you can put the pads on right away, pull off the patch. Also, if your patient does become unstable and you go to the closest ED, it's very obvious they have a nitro patch because when they take off the shirt to do monitor, pads, things like that, it's easy to access, it's easy to pull off. And if you forgot to mention in triage, they can see it and they know there's one there. Any questions about nitro? All right. So next one we have is hypoglycemia. So we've updated this. So we've removed all the colored boxes. We've consolidated adult, adolescent, and child all into one document. So that way, if you're on a call, it's a lot less looking through different care maps. So there is still two separate algorithms for adolescent, adult, and infant child, but they're all in one document as E10 hypoglycemia now. So as always, we have our scope of work information. And our indications for accessing this care map is if you have confirmed hypoglycemia as indicated by a glucose check. So we're looking at greater than 10. If they're less than 4, that's concern for hypoglycemia. But also with that, we also have to look at, is this patient diabetic? What's their normal blood sugar? Because if they're usually trucking along and have normal blood sugar at 12 and now they're at 6, that could be hypoglycemic for them. So these are more like guidelines. So again, always use your numbers with your assessment. Don't just go by the numbers alone. With kids, it's a little lower. So if they're less than 10, we're looking at 3.3 or less is hypoglycemia, because, and the thing to keep in mind with kids is that they may be diabetic and not been diagnosed yet. So we kind of have to go with the assessment of what's been going on, things like that. Especially when we look at infants with little ones, if they have some kind of respiratory infection, they may not be able to eat properly. So that can cause a drop in blood sugar. So it may not be that they're diabetic or they have that kind of problem. It just could be that they're not eating properly because they can't breathe through their noses when they're trying to have their bottle. So with that as well, always try to attempt to ascertain what normal blood glucose is for each patient. If they don't know, and see if you can get back to their normal level. So also it says suspected hypoglycemia when blood glucose measurement is not readily available. So if your patient's combative, you can't actually get a blood sugar and the family's like, oh, he's diabetic, this happened last time. It's pretty straightforward on your assessment. So even though you don't have a number, based on your assessment patient history, you can just assume that they're hypoglycemic and start doing therapy. Some things to keep in mind as well is some patients with long-standing diabetes may develop autonomic neuropathy, causing patients to no longer exhibit classic symptoms like the fatigue, slurred speech, decreased LOC. They may just go right to lethargy, confusion, like unconscious, and have seizures. So it may not have that gradual change as the blood sugar drops. They may just drop and start seizing. Symptoms in infants and patients that are pre-verbal. So like, you got your toddlers, they can't really talk yet, tell you like, I don't feel good, my head's spinning. A lot of times they can present as irritable, lethargic, they're not feeding. They could have cyanosis, tremors. So with that, pediatric patients may not show a lot. Like they might just be really fussy, and the parents might say, well, he's been fussier than usual, something's not right, he's really tired. And then we don't really realize that they're hypoglycemic to actually start seizing, and that's when people call us. So anytime there's a seizure, do a blood sugar. So contraindications, obviously, if we're not suspecting hypoglycemia, the blood sugar's fine, we're not going to access this care amount. So like I said before, it's broken down to adult, adolescent, child, and infant. So we're going to look at the algorithm here for adult and adolescent. So the first thing we're going to look at is the patient alert and cooperative and able to swallow. So if they are, we're going to give oral glucose as per medication profile M06.1. If no signs of improvement after 3 minutes, you could do another blood sugar, see if it even did anything. It may take a while for some people to turn back to their normal level because 1 tube of sugar may not be enough. If they haven't eaten for a couple of days, it's probably not going to fix your problem. So there ideally should be a rapid improvement in their level of conscious after administration of glucose or dextrose. So if there is no improvement, try to give more oral glucose or just glucose in general. And also look for underlying causes, like what's causing the hypoglycemia? Are they really sick? Is there something else going on, some other medical condition that's affecting, such as an infection, that's affecting their blood sugar levels? Always keep trying to treat their blood sugar, look for other causes, and repeat your patient signs, symptoms assessment with your blood sugar every 10 minutes just to make sure everything's good, or if you need to repeat your therapy. And then transport. And again, keep reassessing your patient. If they're doing great, awesome, but we want to keep an eye on it because I'm sure a lot of people can attest to this. When we give sugars, their blood sugar is really high and then it can start dropping. So that's why we want to keep reassessing these patients because giving a tube of sugar is kind of a temporary fix. So is the patient alert and cooperative and able to swallow? If the answer is no, we're going to look at giving dextrose. So we can give oral glucose buccally. That's going to, if anybody's ever done that, it's messy, it takes time, but that's something you can do in the meantime while you're getting your IV set up, things like that. So don't just rule it out and say we're going straight to IV because it may not be an easy way might not be easy to get an IV right away. It's going to take time to drop our meds. So we can start putting glucose in their gums. So you get your partner to do that while you're getting your IV set up just to help prevent seizures. Because if their blood sugar is dropping rapidly, we don't want them seizing. So we can start giving oral glucose. As long as there's not a big risk of aspiration or worried about getting your finger bit. So we're going to administer dextrose as per dosing in M06.2 dextrose. So it's 5 mL per kg D10 to a single max dose of 250 for adult and adolescent. If you're worried about fluid overloads, you got a CH patient, you got some crackling in the lungs, but they're hypoglycemic, and we're like, well, if I dump 250 in this guy, I'm just going to load up his lungs with fluid. We don't want to drown our patients in D10, so we can give D50 at the dose of 0.5 grams per kilogram. So the big thing here talks about glucagon. This EMRs can give glucagon still, but they have to consult online medical support first, and that's just intranasally. PCPs and above may administer glucagon any route as per M06.3 glucagon, which we're going to talk about in a few minutes. ICPs can consider doing an IO if you have no other options. So your patient's unconscious, they just had a seizure, we can't get an IV, oral glucose, I'm not putting my fingers in their mouth, they're seizing. We can look at doing IO to give D10. So if you give them medication, so you give your 250 mLs of D10 and they're not getting better, reassess and retreat your therapy. So just keep reassessing, are your therapies working, yes or no? And again, if you're doing multiple therapies and they're not working, start looking for other causes as well. It may not just be hypoglycemia is the problem here. And of course, transport and keep reassessing your patient. So moving on to algorithm B now. So this is for infant and child, so basically 10 years and under. So one thing to keep in mind, so I just got some pictures here of where you could also do blood sugars for babies. Because when we think about it, when you think about the Lancet, when we actually poke the babies to get, poke patients to get blood, if they've got little tiny fingers, so if we try to do a finger stick, the needle might actually just go right into their finger, which we don't really want to be poking their bone. That's not going to help us. So other alternative places to do your blood sugars for smaller patients is the big toe of the foot, the heel of the foot. As you can see in the one picture there. But if kids are older, like 8, 9, you can still do a finger stick. So kind of take your choice of where you want to do your blood sugar checks based on the size of your patient. So you do your blood sugar check and your patient comes back as the blood sugar less than 3.3 or hypoglycemia is strongly suspected. You can give oral glucose, again, as long as there's no risk of aspiration. PCPs can administer dextrose, so PCPs and up can just give IV dextrose to these kids. So because their D10 is weight-based for kids and infants, we're going to, if we don't know the weight of the child, we can use Brazo tape. So just a quick review here. So to use a Brazo tape, the red end of the tape goes to the head. You lay it flat, make sure there's no folds, because if it's folded over, you're going to get your kilograms incorrect because it's obviously going to be off. So you want it as flat as possible next to the child. And then we lay it down, so red to the head, and then we go to the heels. And at the heel, that's the kilograms that we're going to use for our dosaging. So one question that I get asked a lot is, what if it's a really big child? So they have a lot of adipose tissue. So there's a couple of options. One is to go to the next weight up. So what if, let's say they're at 22 kilograms, we'd go up to 24. The next color up on the Brazo tape, or you just go with whatever the Brazo tape says, give that dose, and you can always give more if you need to. So if you're worried about overdosing your kid because you're like, well, I'm kind of guesstimating the weight here, I'm not comfortable with that, give based on the Brazo tape, and then you can always give more if you're worried about overdosing your kid. So if IV access cannot be achieved, so EMRs again, so you can give intranasal glucagon, but you have to contact online medical first. PCPs and above can administer glucagon intranasal IM. So as per M06.3, if they're greater than 20 kilograms, they get the whole 1 milligram. If they're less than 20 kilograms, you give them 0.5. It's a half dose. If there's no other options for medication administration, again, IOs, you can do this on pediatric patients. Because again, if you've got little ones, they're not always the easiest place to start IVs, so IO might be a more viable option for you. So again, we always want to be reassessing the patient for signs, see if they're improving, recheck blood sugar, do it before you give therapy, give it after, and just continue to monitor your patient. And transport, keep monitoring during your transport. Any questions about hypoglycemia? So, seeing as we're talking about hypoglycemia, we're going to talk about glucagon next and just the updates to glucagon. So, as I said before, the new change is that EMRs with basic work scopes can only give medication intranasally after consultation with online medical support. So, as an EMR, you are able to give glucagon, but you got to contact the physicians first. So, indications for this, very similar to what we just talked about with the hypoglycemia care map. So, we confirm they're hypoglycemic or we have a high suspicion of hypoglycemia. So no contraindications, because basically with glucagon, if they're not hypoglycemic, we're not going to give it. So for this, for 10 years and up, it's 1 milligram straight up for intranasal. For 12 months up to 10 years. So if we go by weight, so again, we can get the Brazo tape out if we're not sure of their weight, because if the kid's unconscious, parents tend to panic and they forget what the weight of their kid is. So if they're greater than 20 kilograms, you give them a full dose. If it's less than 20 kilograms, you give a half dose, so 0.5 milligrams, and repeat once in 10 minutes if required. So with this here, you can repeat it in 10 minutes because with intranasal, we don't know how well the absorption rate is going to be. So we might not get a great result. So that's why we want to give it again in 10 minutes if we're not noticing the changes that we're wanting in our patients. Big thing is as well, COVID-19 still a thing. So whenever you're using intranasal meds, we always want to wear extended PPE. So for intramuscular dosing, so for this here, if they're greater than 10, it's just, again, straight up 1 milligram. If it's 12 months to 10 years, again, it's weight-based dosing. And again, repeat once in 10 minutes if required. So IM might take a little longer to work than intranasal. So keep that in mind. Also, you have to look at perfusion because they've been seizing. If you're giving it a muscle that hasn't really got great perfusion yet because they're just starting to come out of that seizure, they're post-ictal, IM may not be your best route. But just keep in mind that it's absorption. We don't know how long it's going to take. So just keep reassessing. And again, if they have any bleeding disorders or anticoagulation, we always just have to begin, we're stabbing them with a needle. So just something to keep in mind. So for IVIO dosing, again, intranasal, intramuscular, intravenous, it's all the same dosing. So 10 years and up, 1 milligram, and then under 10, it's weight-based. And this one you can repeat in 5 minutes if you need to. And again, IO access if you really need to. One thing to bring up when we give it IV is that because we're giving it faster, it's going to have a rapid rate of absorption through the IV. It can make your patients nauseous. So think about giving an anti-nausant. So basically, if you're looking at Gravol, Maxaran, and Danzatron, kind of figure out what's going to work best for your patient. If they're already kind of sedated, maybe do not use Gravol, right? Because Gravol can make our patients sedated. So if you're worried about altering their LC, it's like, is it their hypoglycemia? Is it the Gravol? Maybe something like Maxaran or Danzatron might be a little bit better choice. It's kind of up to you what you think would be best for your patient. So if glucagon's given, ensure the patient eats something right away because it really works on their stores. So if they don't have a lot of stores, especially the little ones that haven't been eating, it may not work for them. So we want to try and follow up with some kind of food. And glucagon has also been shown to have less of an increase in blood sugar in type 1 diabetics versus type 2. So if you've got a type 1 diabetic and it's not really working that great, then you might have to give some other therapies. The other thing to keep in mind with glucagon, it acts only on liver glycogen, converting it to glucose. So if the patient's in a state of starvation or malnourished, so when we look at it, we look like people that have substance abuse issues where they're not really getting the best diet. Someone's been having meth 3 times a day instead of food. Probably is not going to have a lot of glycogen stores. So when it comes to that, glucagon may not work. So if it does work, that's what we want to give them eat right away. So it'll give something for their body to work with while you're getting their LC up. Any questions about that? All right. So last one we're going to go over here is MIDAZOLAM. So this one, again, just like everything else, we have scope practice here. So it's for PCPs and up. So indications for this, so intranasal. So if there's active seizures, when intramuscular, intravascular admin is not safe or rapidly available. Respiratory depression and hypotension can occur after medication administration, especially when the patient is post-ictal. So we want to make sure we're constantly monitoring the respiratory status, cardiac status, things like that. So when giving intramuscular, it's not safe or readily available. So it says here, the following when intravascular administration not safe or rapidly available. So if you're not going to go intranasal, you can go IM. So for seizures, usually IN's the go-to because if they're seizing, we may not want to introduce needles. But if we're going to use chemical restraint, alcohol, benzodiazepine withdrawal, or stimulant intoxication, you can use IM for that. When it comes to IV, again, same thing. If you got an IV in place and they're seizing, yeah, give it through the IV. It's going to work a lot faster than giving intranasal. And I also find just a lot of paramedics prefer to do that because then you don't have to put all the extended PPE on before they start treating their patient intranasally. So if there's active seizing, you're using it for chemical restraint. If there's alcohol, benzo withdrawal. If they have stimulant intoxication, so when we talk about that, it's like the use of something like MDMA, cocaine, methamphetamines. We can give midazolam for that. And if an advanced airway is in place, you want to maintain it if they're waking up. But the thing is, you have to keep in mind is do we have an airway in until we get their breathing back? So if they've got an opiate overdose, they give them Narcan. So we're ventilating them, we give them Narcan, they start waking up. We may not want to keep that airway in place because the whole goal is to get them to breathing on their own. But if they're constantly vomiting, there's concerns for aspiration, things like that, it might be in the benefit of the patient to have the IGL in, or when you're on IFT, obviously, if they've got an ET tube in place, we want to give them midazolam to maintain that airway. Okay. Big thing here though, when it says advanced airway maintenance, so we never sedate a patient to put an airway in. So if they are conscious and we're like, oh, they could really benefit from having an I-gel because they're breathing so fast, but I can't bag them, I can only passively oxygenate, I really want to put an I-gel in to help ventilate them, don't give them a DAS. We do not sedate patients to put the airways in, only to maintain the airways. And so also with that being said, for ICP only, it says procedural sedation. So that's things such as like if you're going to do cardioversion, if they're hemodynamically stable enough to give midazolam 2, but we need to cardiovert them because they're starting to not do too well, then we can give them midazolam first. So contraindications, obviously, if they've had bad reactions to midazolam in the past, if they've got uncorrected hypotension, as midazolam can worsen that. The same thing with respiratory depression, midazolam can reduce respiratory drag. So with this here, the new update that's been added to this medication profile is one of the former contraindications was CNS depression. That's been removed. So now it's been taken out. So it's only these 3 contraindications. So for PCP and up intranasal, and again, wearing your extended PPE, if they're over 10, you give them 5 milligrams. And if they're 12 months to 10 years, it's weight-based. So again, you can use the Brazel tape for this. So it's 2 milligrams per kilogram, 0.2 milligrams per kilogram, sorry, to a single max dose of the adult max. You can give it once in 10 minutes if seizures persist or reoccur. And if you're going to give it all in one nostril for one spray, alternate nostrils back and forth. That way it just helps with absorption. So for dosing intramuscular, so basically the same thing as we did for intranasal, and just use caution if you're giving IM. So this one's repeat every 30 minutes because again, IM takes a little bit longer to absorb. So it may be variable with the different absorption rates in patients. So again, a healthy 12-year-old versus a patient that's 89 that has like every medical condition known to man, like their circulation may not be that great. So it can affect differently for absorption rates. So when it comes to IV IO dosing, so with this one here, it's weight-based for everybody over the age of 1. One question that's come up a couple times that I've asked by paramedics, like what if your patient's less than 1 and they're seizing? So these med profiles are standing orders. They give us the dose we're supposed to give. If it's not in the standing orders, we need an order for it. So if you're going to, let's say a 7-month-old that's repeatedly seizing, we don't have a standing order for that. So you contact Online Medical to confirm dosing for your patient if you're not sure what to do. So for IV dosing, for 1 year and up, it's 0.05 to 0.1 milligrams per kilogram. And you can titrate to effect up to a single dose maximum of 5 milligrams. So like I said before, you want to kind of consider the age and the state of your patients because benzos have more pronounced respiratory and central nervous system effects on the elderly, especially if they're frail or compromised. So if you have a geriatric patient, like I said, has a lot of like cardiac respiratory issues already, we may want to give them on dose on the smaller side. And we may want to look at, we need to give it slowly, right? So it says administer over 60 seconds. So if you push your midazolam too fast, it can cause respiratory depression or respiratory arrest and increase risk of hypotension. So let's say you have a pediatric patient, so you're at the 13 months, just over a year old, and you're drawing up your dose and it's such a minuscule amount. So let's say like you're giving like, I don't know, like 0.2, 0.3 mLs. It's gonna be really hard to slow push that over a minute. So what might be recommended is to get your dose of midazolam and just like 1 cc syringe or whatever size syringe you prefer. As long as you're doing medication dosage properly, dilute it with saline, and then you can slow push it. So, but the big thing to take home here is that you do not need to routinely dilute midazolam. It's only if you've got that small amount, it's really hard to push over a minute, then you can add some saline, and it needs to be saline, not ringers. Dilute it with saline, that way you can slow push it. If you're given the whole 5 milligrams and you're like, okay, yeah, I can slow push this over a minute, not a problem, you don't need to dilute it. If you're going to give it intranasal IM, definitely don't dilute it. It's just a straight shot. It's only IV. If you can't push it slowly, then you can look at diluting it just so it's easier to administrate. So over here, then it's got all the repeats. So for seizures, every 5 minutes as required. So there's no timeout on that because obviously if they keep seizing. But again, you also have to look at is I'm giving them a DAS, I'm giving them a DAS, I'm giving them a DAS. They're still seizing. Look for other causes. Contact Online Medical if you're kind of like I can't stop their seizing. I don't know why. So always look for other causes as well. So if they're going through alcohol or benzo withdrawal, repeat it every 10 to 20 minutes. If they have stimulant intoxication, so they did way too much cocaine at the party tonight, we can give them a DAS every 10 to 20 minutes as required. Chemical restraint, you can repeat every 10 to 20 minutes as required as well. I'm noticing a trend here. So advanced airway management, repeat every 10 to 20 minutes as required. And for procedural sedation, you can repeat it every 3 to 5 minutes as required. So again, we always want to be monitoring their respiratory drive, their blood pressure, doing vital signs between those. We don't just keep firing midazolam in our patients. Obviously, combative patients are a little bit different because if they're combative, it may not always be safe to check a blood pressure every 10 minutes. But we always want to be watching their respiratory drive and their blood pressure if we can. Because we don't want to be driving them down just because we're spraying we're spraying midazolam up their nose every couple minutes. Any questions about midazolam? All right, well, that's all I have for the care map updates. Thank you for sitting in. I am recording this and I will be uploading it to the YouTube channel later today. So if there's no other questions,